occur during perimenopause being the 2 to 10 year period prior to menopause, which is cessation of menstrual cycles. And we just know so little about it, right? So, 3% of research, it's something like, I think it's 0.5% of research in terms of female brains during menopause is really, 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 really low. So we don't really have a lot of information. And there are so many different symptoms that we can experience. Everybody thinks about hot flashes, but there are many more than that. And I think that's why people drop out of the workforce, because they don't realize what's happening. Like musculoskeletal, I'm now getting arthritis in my joints, and it's a menopause-related symptom. And sometimes people will say, well, it's just aging. It's not that, there's a little bit of that. But if you think about the loss of ovarian hormones, we have estrogen receptors, progesterone receptors. They're everywhere across our body, right? Not just in the parts that we cover with a bikini. They're everywhere. And so it makes sense that when we lose these hormones, we're going to experience many different kinds of symptoms. So I just research.
Awesome. I know I want more, but I've got 2 more questions that I need to get out. And so I want to go to Jocelyn before I get to Jean and Linda. Jocelyn, coercive control. We talk about it. We know that 30% of women may show up showing harms of abuse, bruises. But that other 70%, a lot of it is coercive control. It is controlling of an individual. What do we need to do when it comes to coercive control? Because we know the impact, it's all mental. What can we do there?
Thank you. I think that's an excellent point. I think sometimes we get caught up in looking at the physical symptoms of things, and unfortunately I think we live in a society in Canada that follows a lot of the same guidelines of policing, where it's like, I need this hard evidence, I need to see it with my face in order to believe it happens. Meanwhile, our center and all of the other sexual assault centers are operating on the basis of, like, if this is your experience, if these are the emotions you're feeling, then that is the evidence I need to support you. So a lot more work, even if it is in physical health spaces, needs to just be around how can we create a more trauma-informed space, right? How can we make sure that everybody that walks through the door feels as safe as possible, so that even if they're not going to be showing a physical sign of injury, but if they are mentioning that, oh, well, I'm not allowed to go here because of this, or, oh, my partner holds onto my phone, my partner needs to do that, we don't just ignore that, and we know kind of how to ask some more probing questions about that and provide space for them.
And when we talk about trauma, that's why I'm leaving it to you, Jean and Linda, because the first time I met you during COVID, we talked about a young woman being tied to, a radiator. I think that was one of the first stories that you shared with me. And when we're looking at counseling, what is available? Because it's so, you can't even get into a counselor just for simple mental health issues, and I know anxiety is not simple, but when we're talking about the complex trauma of human trafficking, what is available? Who is educated to help counseling? What do we have here in Canada to help save some of these young women from the mental torture that they're going to continue for the rest of their lives? What can we do?
Well, as far as the torture in human trafficking, the only place that we know that took on the model that we created was in the London Abuse Centre. Other than that, we have emails. I answered an email this week from a woman whose daughter was tortured in trafficking, and I just have to tell her, in Canada, where you live, there's no one that I know of that can help, not in the way that she needs. And I just wanted to tell some of the reasons why the victimization trauma-informed care is so important, because things disappear, like they stop being suicidal. They stop being triggered. They stop disassociating. They were able to sleep at night. They go off medication. They go off disability. They get a quality of life where they can have fun and joy and just be free to be themselves. And so the story is, I know it's hard to read at night, Anna, but the story is a good story because it's a positive story if we just embrace their reality and know that if you can heal from torture, you can heal from anything, because it's the worst crime on the face of the earth. And there's no place for them in this country yet, because we don't have the law, and then of course because we don't have the law, we don't have the care that they need and deserve.
Okay. Thank you so much.
Thank you, Ms. McDonald. Next, Dr. Hanley, please, for 5 minutes.
Yes, thank you so much to all of you for being here. I think I'm going to start with Ms. Enright. You talked about not having funding for under 16 at your center, but could you briefly talk about what would be available in your area for that age group, for children and younger youth?
Yeah. Unfortunately, there's not a lot. I think the assumption is because we have a duty to report to police and CAS or appropriate services when somebody under 16 has been harmed, it's assumed that we call them and then we let them handle that, when we know that a lot of those scenarios, again, are incredibly harmful, come with a lot of stigma, and people might not be treated in the right way. So yes, I can of course call the police for something when it's somebody under 16. If they decide that there's not enough evidence, then I can't offer counseling for them. And I'm stuck with saying, here is a child and youth center that has a 1 to 2 year wait list potentially. I don't know if they've changed, but over COVID in Peterborough, we were looking at least 2 years for most of our child and youth service wait lists. And I can't guarantee that the workers there, I'm sure they're wonderful at their jobs, but I don't know if they have the specific training to work with survivors of sexual abuse, which often needs different ways of looking at it. We often can't use a particular modality without making some changes to make it more trauma-informed. So unfortunately, those are our options right now, and we're kind of left in a position of not having a lot to send for people.
Thank you. And speaking of funding, and you talked about where the federal government might have a role, and I think part of it was to looking at, it sounds like engaging with the provincial government about core funding, but also boosting other sources of funding. So pre-budget announcement recently from Minister Sachs, I think it was pretty good news, $500 million dedicated towards youth mental health. So let's say you had a slice of that funding. Where would you put it? Where would you see in your community that you would go first? And I know it may depend on how much, but let's say you had a chunk.
I was told our dream was $700,000 more would be the bare minimum for us to have core funding to support who we're supporting and who we're missing as well, because that's the huge thing, is we can do as much as we can to create as safe a place as possible. I'm trying to provide my voice for that, but we're missing a lot of people are falling through those cracks. So yes, I understand the need for all sorts of childhood mental health, but again, looking at all of those different sections. So not just saying mental health, but looking at, okay, we could mitigate a lot of those mental health things by putting the money into centers like ours. Okay, great, let's do that. I think a lot of times we don't consider children who are coming from domestic abuse situations. It's not as simple as saying, okay, we'll leave this situation. Well, can I go to a shelter if I have my children? Is the shelter low barrier? What if I am using substances to cope with that sort of stuff? What if my children are using substances to cope with that? So putting funding into that as well. So I think a lot of that could be in getting people those basic necessities if they're leaving those situations. And then also, again, looking to maybe organizations that people don't think of right away. We might think, okay, put it into mental health, but if you put it into different forms of things, into torture, into, the work that we're doing with sexual assault, then chances are you might see decreases of further mental health disorders.
Thank you. I'm going to move to Dr. Galea. There's so many questions for you, but you talked about getting things published about women's health studies. How is it about the content? Is there any role in being a woman doing the research? Does that play into it at all as a female researcher?
100%. So we tend to research what we are interested in, and we're interested in things that we've experienced. So I'll give you a really good example of this. And I experienced this very badly during pregnancy. I had nausea and vomiting, and I was told it was just in my head. And I had a fantastic healthcare provider. I just want to make it clear, fantastic healthcare provider. They just haven't had the schooling, because we don't have the research and knowing some of these. So she told me, don't worry about it. It's all in your head. If I could admit you to a hospital, but it would go away. And I just, sucked it up, because that's what you do. And fast forward, my son is now 27 years old. So fast forward 27 years, and we now know that there's a hormone called F-15. And it was discovered by, and I'm sorry, I've forgotten the person's name, but she's in the States. And the reason she wanted to do it is because she suffered very extreme nausea and vomiting during pregnancy and actually ended up losing her baby. That's the other thing we're told, though, oh, it's fine, it's really, really safe, but actually not for some people. So she was a geneticist. So she started to look, is there a genetic factor for it, and found this hormone. Now there are some, putative treatments that we can use for people that have really severe nausea and vomiting during pregnancy. When she told her lab, this is what I want to start studying, they laughed at her. But, she persevered because this is an experience she'd had. She wanted to know, what does this mean? Why is this happening? And so, women scientists were more likely, the data is not 100%, but we are more likely to work on the issues that matter to us. So it's important to, and as you probably know, like in many areas, we don't tend to move up the ladder as
Thank
well.
you. Thank you,
very
Dr.
much.
Kalia. Suite, Madame Laroche pour 2 minutes et demi.
And then now on to Ms. LaRouche for 2.5 minutes. Thank you very much, Mr. Chair. I will continue my round of questions. I'd like to ask a question to you, Ms. Kalia. Now, I don't really understand that there's such a big difference between financing for research into women's health or diseases or conditions and men on the other hand. And if you could maybe go into detail on that, and why is there such a big gap still in this day and age? Also, you referred to $1 trillion, a number in savings, and where does that statistics come from?
The last, pardon, mon français n'est pas bien. I'll answer the last question first. The 1 trillion figure worldwide we could save if we put more money, if we achieved more knowledge in women's health research, and that's from the World Economic Forum. It's a report that was just released maybe a month ago or so. You asked, so there's no, one of the major federal funding agencies is Canadian Institute for Health Research. They have something like 58 committees, and they'll be on like neuroscience, biology and clinical aspects, because they have aging. None of them are for women's health in particular. There is one on maternal and child health. I've tried to get funding through them. Yeah. I can't get funding through them because it's mostly on the child, as you might imagine. There's another one called Gender and Sex Health or something. That's what it's called, GSH. That's where I tend to get my funding. I have been told, and if you look on Twitter/X, you'll see a pinned rant that I have. I got really angry because I put in a grant 5 times on looking at how pregnancy affects the aging brain in that committee, and they kept asking me to add males. I mean, males don't get pregnant, so I couldn't do the work that they wanted me to do. It's also the lack of research, the lack of publications in this area is this mistaken belief that girls and females and women are harder to study because they're more hormonal, right? We have these menstrual cycle phase, and so we're more difficult to handle or more difficult to interpret. However, just for a little bit of levity, human males have a 50% decline in testosterone that occurs daily. So I have one little thing that I say, which is, given the monthly fluctuation in females and a daily fluctuation in males, who's more hormonal now, right? And there have been many studies done to show that there's no difference in variability within each sex. I can't tell you. I wish I knew the answer.
I interrupt with great reluctance.
Yep.
Ms. Kazan, please, for 2.5 minutes.
I'm not sure if anybody can answer this, but I was really shocked. 2 days ago, there was a woman from Mexico who was denied a C-section in Edmonton until she came up with $5,000 to do so. I've been really pushing for status for all for these kinds of reasons, safety factors for women. You spoke a little bit about, mental health. I'm wondering if perhaps Madame Enright, Dr. Fairbrother, or Galea could answer how that places women's health at risk, current systemic racism within our system. I call it systemic racism. Can somebody answer that?
I can say just a little bit about that from my own experience. I've had a number of conversations over the past 10 years with Indigenous women who have spoken to me about mental health concerns. And when I hear their stories of some of their experience within the healthcare system, within psychiatry, the feeling I have is surreal. I feel like they are reading from a recent news article describing the problem. It sounds like, and I don't mean this in the trivializing sense, it sounds like a cliche. What they're describing is what we've all received notification about, or we've seen headlines talking about. And then they're telling me these stories that map on exactly to that, and it feels extraordinary to me. And so I think I had maybe the hope or the impression that given that this has become better known, that this would not still be happening, and clearly it is still a very serious and ongoing concern.
I appreciate that because as I asked you on break, we know forced sterilization of Indigenous women continues to happen in this country. So discrimination is certainly not new in our healthcare system. I was horrified. I just thought, oh my goodness, what much she had been going through when she was denied to be able to deliver a baby in a hospital. How can this be allowed? Do you have any comments?
Just very briefly, if you can. We're out of time.
Yeah, that is okay. I'm not as well versed with the healthcare system, but certainly we work with women all the time who are discussing about how they don't feel comfortable going to the hospital for anything related to any health issues because of the systemic discrimination that they face. And I think it's, the fact you're saying, like, being denied something that you think, is this not just a basic human right in Canada for me to be able to go into here and have, like, this procedure that is just basic, like, it seems so simple, but it's not happening. And we see a lot of the same with our survivors going in for anything related. As soon as they identify as being a woman, as soon as they identify going through any sort of trauma or sexual violence, they are treated incredibly differently.
Thank you. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. I really appreciate all the witnesses being here. And I'm going to focus a little bit of my questions specifically to Dr. Fairbrother and Dr. Galea. I shared with you guys before our committee started about how I am a mom to 2 little boys. And specifically on the prenatal or the perinatal mental health and the anxiety piece, that wasn't something I even knew existed. And when I had my first son, I didn't have any of those experiences. And very shortly after having my second son, I realized that my anxiety was, like, crippling out of control. And I felt like maybe there was something wrong, and he was born a month early. There was a lot of extra stress. So I just assumed that, like, clearly I was anxious and there was something to be anxious about. And it took actually finding some of your ladies' research that helped me realize, like, hey, wait, this is just like a normal phenomena. This too shall pass. I am fine. It's all good. And I share that because I didn't even know that it existed. So I was wondering, what recommendations would you have that we could put forward on improving this aspect? So I'll leave it to both of you ladies.
Yeah, so I think you're absolutely right. The difficulty is that if you look at major depressive disorder, which is the major depression and postpartum psychosis are probably the 2 mental health conditions that have received the most media attention, the most research, etc. So they are the 2 conditions that people know the most about. Postpartum depression, it affects approximately 6% of new moms as a major depressive disorder, versus anxiety disorders, it's 21%. And all of the research and attention that has been given to depression and to psychosis is well deserved. It's lovely. However, we have not spent any amount of time really giving attention to these anxiety difficulties that are much more common. So as a starting point, even just naming this. So I will often speak to people who say, oh, I had postpartum. They don't even qualify with what kind of postpartum. And there's the assumption of depression. So if you go into a physician's office and they start asking you about depression and you have some elevated symptoms of depression, it is quite possible the reason you're depressed is because you're suffering from an anxiety disorder that nobody's asked about and nobody has talked about, and yet you're getting diagnosed with depression because the consequence of that disorder is depressed mood, but it's not on anyone's radar. So I think that we need some increased public information about that so that people are more aware that it exists. Someone earlier had spoken about prenatal education. Information about what that looks like is really important, and additional dedicated research so that we can learn more about this. And in fact, research looking at, do people know? Are people well informed? And what could we do to ensure that new parents come into this with better information? Lisa?
And Dr. Gallia?
I was writing down a whole bunch of things. Obviously, my big message here is research, research, research. We know so little about what happens to the maternal brain. As I said, there are a number of biological signatures that occur, and I would love to do some jokes, but I know I don't have time for them, cross-pregnancy and then postpartum. And those signatures mirror what happens in a number of psychiatric disorders, including depression. I probably disagree with my colleague a little bit on the numbers there, but that's not the point. The point is that it is a really time of really great susceptibility, and we need to provide people with the tools that they need to understand this. There's a really great new discovery that just came out of CAMH. It's Jeffrey Meyer. It would have been out yesterday, I think, in the news. And so he's looked at some supplements, looking at evidence-based information of what's missing, what are these biological signals, and how can we better serve people. Psychosis, I would disagree that I don't think most people know that you can get, thoughts and psychosis and schizophrenia-like kinds of symptoms after giving birth. That's not, it's only about 1% of people that will have that, but it's pretty significant. And Patricia Thomasai has a really great article. They did a big piece on her in Toronto Life, if you want to take a look at it.
Thank you. I appreciate it, and if you could table any of that extra information with the committee, that would be very useful. I would like to move a motion that I have put on the order paper, and I think it's very timely considering we're studying women's health. And it's, Mr. Chair, that pursuant to Standing Order 1082, the committee undertake a 2-meeting study on breast cancer screening guidelines in Canada, including but not limited to an examination of A, current breast cancer screening guidelines, B, Breast Cancer Canada's recommendation to lower breast cancer screening guidelines to begin at age 40, C, Breast Cancer Canada's recommendation that Canadian guidelines for the screening, detection, and treatment for breast cancer be updated every 2 years, D, best practices in treatment and options to improve health outcomes, and the committee report its findings and recommendations to the House, and that pursuant to Standing Order 109, the committee requests the government table a comprehensive response to this report. Part of why I am moving this in this space, not only is that April is Cancer Awareness Month, but for people like myself, I lost my mom in 2010. She was 49 years old to breast cancer. And I know that had earlier breast cancer screening been available, I might have been able to talk to my mom when I was going through postpartum anxiety and see if that was something she had. But I didn't have that resource. So many women don't have this as a direct result of these screening guidelines not being in place. And so I am doing this in honor of my mom and all of the women that will benefit, and the families and society. And so, Mr. Chair, I will move my motion, and I hope that everyone will support it so that we can get a study on this very important topic.
Well, Ms. Goodrich, in spite of your personal connection and your passionate presentation of the motion is actually not in order. because we are currently undertaking a study and the motion calls for us to undertake a new study, so we can accept your motion as notice of a motion to be debated at a later date, unless there is unanimous consent to basically adopt the motion as is, which would thereby dispense with the need for notice, but would also not allow for any debate. So shall we take it as notice, or are you seeking UC?
Seek unanimous consent.
Okay,
Mr. Chair.
so the motion is before the committee to seek unanimous consent to adopt it as is. So that goes right. So I would ask: is there unanimous consent to adopt the motion? Okay, sorry. Oh, I guess I need unanimous consent to be allowed to move the motion, but I think I just got unanimous consent for the motion. So, okay. So I take it there's unanimous consent to move the motion?
Yes.
Can I then open debate? Okay. So I'm now advised that because she has unanimous consent to move the motion, that it isn't not debatable, and if anybody wants to speak on it, the floor is open. Dr. Pawlowski.
I think we want to get back to the witnesses, so we support the motion.
Any further interventions on the motion? Are we ready for the question? All those in... No further interventions? Ms. Kazan, all those in favor of the motion, please raise your hand. The motion is adopted. Thank you, Ms. Goodrich. Then that also concludes your time and brings us to Dr. Pawlowski for 5 minutes.
I'd like to ask all you probably some questions, but I'm going to concentrate on Dr. Fairbrother. Maybe you could start off with, and please try to make this part of it, your answer really quick. You cited that numbers that 50% of women had thoughts of harming their baby. Do you want to just quickly, like 30 seconds, give me some citations? How many, like what sample
Yes,
size?
so a number of different investigators have looked at this. Jonathan Abramowitz in particular, and then me. I focus specifically on harm thoughts. I have 2 publications on this. The first was about 100 people. The second was about 400 people. In both instances, first time, it was 49% who reported unwanted, intrusive thoughts of hurting their baby on purpose. In the second iteration of about, I don't know, somewhere between 400 and 700 people, I'd have to look up the exact numbers of who reported this, we had 54% reported unwanted intrusive thoughts of hurting their baby on purpose. We have twice now in both of those studies looked at whether or not the people who reported these thoughts of hurting their baby on purpose were actually harming their infant, and whether or not that was happening more often in that group than the people who did not report the thoughts of hurting their baby on purpose. And to date, we have found 0 evidence. And the raw numbers, in fact, would suggest that the people with those thoughts may possibly, if we had a large enough sample, be slightly less likely to hurt their infant.
No, I would take it this is very stressful for women who have these thoughts, and is there evidence that this contributes to depression and anxiety in women, and how much would that be alleviated by the fact that they could talk to somebody about it without having to worry about losing their child?
Yeah, so it is very upsetting for some people. Some people are able to cope with those thoughts okay, but for a lot of people that is very distressing. What we know is that obsessive compulsive disorder, which is the mental health condition most likely to arise as a result of these kinds of thoughts, may in fact impact as many as 17% of postpartum people. That is not exclusive to the thoughts of hurting your baby on purpose, but also encompasses thoughts that your baby may be harmed by accident. And I think as a first step, what we really want to know, my first step on this, is if we educate people prenatally about these thoughts, how much of that will be mitigated, right? Like, I think that's your really most important first step, because you may be able to get a long distance from just doing that. And what you can't do, then those are the people who are going to require some treatment postpartum.
I've worked a long time as a doctor. I've delivered lots of babies, but in my involvement in prenatal care has been like blood pressure and protein urine, that kind of things, and mostly in developing countries. So, but in Canada now, do most practitioners looking after pregnant women, is this part of the discussion that they have with mothers?
No. It's not non-existent. but it is far, far from common. Many, many healthcare practitioners, unfortunately, know very little about these thoughts, and they're either not mentioned or responded to as if all thoughts of hurting one's baby on purpose are harbingers of child abuse, which is not the case.
No, I would have thought these kind of thoughts would be most stressful to people who themselves either experienced child abuse or have seen siblings experiencing child abuse. But I want to get to the next part of the question, which is differences as to how mothers are treated according to their race, and a higher incidence probably of intervention when Indigenous women report such things. I'd be pretty sure that as an emergency room doctor, and worked in a lot of emergency rooms, I'd be pretty sure if you had an Indigenous woman and routinely the doctor would refer it to child care services. But my guess is across Canada in emergency rooms, given that story, and it would depend according to whether you have an Indigenous child care services like you have in Thunder Bay, but other places don't. My guess is if you're an Indigenous woman who says that, you have, especially if you yourself had a history of child abuse, that my guess is your chances of having that kid being taken are really a lot higher. But is there evidence for that? I suppose maybe.
So my research lab is trying to move in that direction, as I think some of your colleagues in this room will really appreciate. As a white person, treading into that sphere is a little more complicated and requires a lot of collaboration from other Indigenous scholars. But that is one of our next moves, is to try to get some data on that, because I think you're absolutely right that that's going to play out really differently, and child removal is almost inevitable with that. But that is anecdotal at this point, and I don't have the data yet for that.
Now, if there's time for a quick question, now the courts, I think, when they look at child custody, they always the best interests of the child come first. But certainly we've heard today of the trauma that to the mothers with losing a child. And when the courts make that balance between the interests of the parent and the interests of the child, do you think generally they're doing that right? And secondly, is that balance change according to whether you're Indigenous or non-Indigenous? And certainly, having said that, let me quickly say, and you talk as a medical practitioner, and you see people who have real drinking disorder, and they're coming to the emerge all the time with high levels of alcohol. They're homeless, and you ask them, like, and you say, you're killing yourself, and you say, yeah, I know. And you ask why, and often losing a child is, I would think, in my experience, one of the most common things you hear. So the courts get the balance right. And I know this is very difficult for the courts, but is there a difference between Indigenous and non-Indigenous?
Just excuse me for 1 second. That was Dr. Poloski's idea of a quick question. Yeah, and he's well past time. If you could answer much more succinctly than he posed the question, that would be helpful.
I'll give it a try. So I wish that I were more of an expert in this area. I think what I could say on this is that the trauma that a mother experiences when losing her child has implications, and heavy implications, for the child. That this is not just a either or, that mother-infant is a duo and almost in some ways exist as a unit. And so what happens for the mother has implications for the child, and her ability to regain custody of her child diminishes as a consequence of that trauma. And so, yeah. So no, I'm not sure we're getting it right.
Thank you. Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. And I assume, Mr. Chair, that by me pleading to you for a little bit more than 5 minutes, I could maybe have more. I assume that's a no. Anyway, I apologize. Thank you for all being here.
Please trust my discretion. You have so far.
Thank you. Today when I first sat here and the chair announced at the beginning of the meeting a warning about what we would be experiencing today, and he made that announcement for those that are watching and listening, and I thought, well, that's the first time I've ever heard a warning being given out, and yet it has been one of the most compelling meetings I've ever been at in my 9 years, to hear the experiences that we've had and the huge impact. And so I have so many questions, but I'll try as quickly as I can. It's when I looked around the room, I saw expressions on people's faces, And it was just astounding to what we heard. And I think I've lived in Afghanistan, Pakistan, Iran. I've been around where people have had their hands cut off. I've been around where there have been hangings. And what I heard today was just more compelling to me than things I've ever heard. So I appreciate and I thank you all for what you do. And it's a huge area. Ms. Enright, you brought up an issue about recognizing that it's a provincial government that provides you your support, and perhaps the federal government can at least show some discretion in the sense of advocating for that. You talked about, I think you said about 4 people that are helping your organization. How many of them are actually making the diagnoses before the people come to you, or are they coming to you with the diagnosis or being referred to you from practitioners?
So the folks can come through our door. Basically, anybody can come through our door. We don't require a diagnosis of anything to receive our services. However, just anecdotally, many of our clients have been to other sorts of therapy and received different diagnoses and then come in. And a lot of times, for some people, it's helpful to receive a diagnosis, but for a lot of other people, women especially, they feel like a lot of times they have gone into the medical system, kind of been told, you have this disorder, here's a pill, goodbye, or been treated with, okay, you're being dramatic, you're being hysterical, the things that we typically hear of women, and then they come here to our center and talk through trauma and realize, like, well, yeah, who wouldn't develop anxiety, who wouldn't develop depression, who wouldn't need some sort of substance to cope after going through something terrible? Am I not just acting the way probably any human being would towards this? Yes, so that's kind of what we're seeing, yeah.
Thank you, and I apologize for interrupting, but I do have short time. Dr. Galea and Dr. Fairbrother, your comments were tremendous, and especially when you talked about depression versus anxiety, and I think a lot of times as a practitioner, I mean, mental health is not my area of expertise. But when I had patients come to me, I would always try to refer and make those referrals, whatever the situation may be. And you pointed out the fact that a lot of times women do not get the diagnoses that they deserve and do not get to the referrals. And for example, cardiovascular disease is a leading cause in women more so than in men. And it's not recognized. And one of the things I've pushed for quite a bit is how do we educate practitioners? Because when they graduate, they immediately, I know when I graduated, I knew everything. And the reality is, when you get out into various areas, how do we educate? Granted, we have a continuing education system that's supposed to be there, but how do we ensure that that actually is happening?
Okay, so I'm going to try and start. As far as I'm aware, because I'm not a medical doctor, as you know, in medical school, there is actually not that much taught about women's health specifically. So I think there's like a morning for menopause. I think there is a week or so for pregnancy. I'm not really sure, but I'm sure it's not about necessarily the mental health of pregnancy or these susceptible times. So we absolutely need more education. To get the education, we still need that research, right? We still need that compass and map. We need more specialties in this. So even a gynecologist, which is what, you have perimenopausal symptoms, you have night sweats, go to the gynecologist, get some hormone therapy if you're a good candidate for that. But, in my experience, anecdotally, but also with my expertise, they don't have all the information that they need, and that's because we just don't have the research on it. If I can just segue another point I wanted to get in really, really quickly, databases. People say, oh, databases are great. We get all these millions of people we can look at. We've tried to do some of this work looking at hormone therapy and how it might affect the brain and different kinds of hormone therapy. That information isn't in the dark. It'll just say hormones.
Thank you. And I apologize, again, just time-wise, when you look at things, one of the other aspects that I think gets missed is actually educating women to truly understand what could be there. And that education needs to come from the practitioner as well as other means, public health, et cetera, such that the women truly understand the potential of mental health issues.
Okay, thank you. Thank you, Dr. Kitchen. Mr. Pawlowski, please. Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to our witnesses. First of all, my sincere apologies that I cannot be there in person, but thank you for being there. I'm going to start with Dr. Fairbrother. Dr. Fairbrother, in your opening remarks, you talked about that approximately 1 in 5 women in Canada struggle with their prenatal mental health. Can you kindly expand on what are the most significant challenges women in Canada face in accessing maternal mental health support, care, and evidence-based treatment?
Thank you very much for that question. Yeah, so I think it is absolutely the case that we're looking at 20% or more pregnant and postpartum people suffering from one or more mental health conditions during pregnancy and the postpartum. A first step in care is adequate screening. For depression, we have great screening. For anxiety disorders, we have yet to identify appropriate tools. I'm very grateful to have a grant right now where we're working to change that particular situation. When you look at pregnancy in particular and a little bit postpartum with breastfeeding, perinatal people really want access to talk therapy because they are concerned about what it might mean to take medication while pregnant and how that may affect their developing infant. And I would say, right now, evidence-based talk therapy in Canada is funded in little tiny corners here and there. I have an entire sheet in my lab for the little tiny pieces that people might be able to get after very long wait lists. So there isn't general access, and if I were to advocate for any subgroup of the population to be really deserving of access to evidence-based talk therapies, I think pregnant people really qualify for that because of these concerns about their infant.
Yeah, thank you. You also talked about, evidence-based treatment, and you talked about public-funded CBT. What other types of evidence-based treatment are currently available in Canada? And also, where do we kind of compare with any jurisdiction, any international best practices? And how can we follow? Anybody?
Let Lisa respond to this portion of the question.
I would just say that, and I believe you heard this repeated on Monday, that we don't have a Canadian perimental mental health strategy in Canada, that was voted against for some reason, but that Australia, the UK, and the US do have this. And so I think that, having guidelines and a strategy for perinatal mental health would go a long way for the healthcare practitioners so that we have that information, and to the people that are pregnant so that they do have that information. In terms of CBT, you're better to answer that one.
Yeah, I mean, outside of reproduction, if you look at the data on treatments for anxiety and anxiety-related disorders, the strongest evidence is for cognitive behavior therapy and additionally for if we're talking about trauma-related cognitive behavior therapy or therapies of that ilk, as well as mindfulness-based approaches, and access is very limited.
Yeah, and I think that's a great point, talking about access. And you also talked about publicly funded CBT, unless you have a private insurance. Those are not available publicly. Can you make a comment on that one?
Yeah, I mean, one of the reasons that I started researching in this area is because I feel very passionately about access to the highest level of healthcare, and it is a very peculiar situation we're in, whereas the treatment of choice, the treatment that has the strongest evidence of effectiveness, is generally not available. So if you were looking at access to medication for a mental health condition, you can probably secure that within a week. If you were looking for publicly funded talk therapy that was evidence-based, you're probably looking at a year or more.
Can I just add to that?
Absolutely, go ahead.
At the Center for Addiction and Mental Health, we have another Women Mind-funded researcher named Daisy Singla, and she just did a very huge study with Simone Weigut, who you heard from on Monday, talking about talk therapy, and they had some really great data showing that you can instruct another person, not necessarily a medical doctor or a healthcare practitioner and a formal healthcare practitioner, to do some of this talk therapy, and that works very, very well. And so that could be a very low-cost thing that Canada could adopt.
I think
Thank
some
you. My time's
dedicated
up.
research looking at that would be incredibly helpful, yeah.
Okay. Thank you. Madame Laroche, pour 2 minutes et demie, s'il vous plaît.
For 2.5 minutes, please. Thank you very much. This will be my last turn, so I'll try to sum up everything that's been said. Ms. MacDonald, you talked about trauma, a lot, and collective rape in hockey circles. At this other committee, we had a main recommendation on that because we've been talking about providing more money to health research, but another recommendation is on the mental health issue and an independent inquiry into this culture of misogyny in these circles. How would you consider that? Do you think that would be a valuable recommendation?
Valuable recommendation. Thank you for the question, but I'd like them to also understand that torture would be involved in the, you don't have the translation. Should I wait?
Is it working now?
Okay.
Okay.
Yeah.
J'espère que mon temps est arrêté.
I hope that my time was paused.
Yes, I think that would be very important, but I also think in studying the misogyny and the violence in sports that we expand our understanding of the type of violence to include torture, especially gang rape, because there's different goals with abuse versus torture with perpetrators. With goal of abuse, the goal is to control the person, the woman, and with torture it is to destroy the woman's sense of self. And I think that's why it's so horrific for women to come forward that have been gang raped, because they're so shattered. If you can imagine rows of men coming at you when you're incapacitated, it's a violation that needs to really be understood in the misogyny that happens in our country.
C'est justement le sujet de la prochaine étude.
That is the subject of the next study that I will be bringing before the status of women, coercive control. So I have just 30 seconds left, but if you could answer the next question. We had a report on mental health of young women, and there is a legislation about hate, online hate. What aspects do you think should be covered when it comes to hate against women?
Is hate against women. I think we have to keep naming it, and we have to keep saying that it's the system. The system does it over and over again. And if we want justice, justice starts on the Hill. It starts with naming the crime so people can tell the truth and be heard and believed. And misogyny prevents that. Very quick, somebody else.
Madame Enright, rapidement sur une loi pour la haine en ligne.
Ms. Enright, what do you think about legislation about online hate?
I think it's incredibly important. I think we see a lot more of that. I do a lot of work going into schools and talking to young kids about this, and young men especially, and it's starting younger. Even when I go in and talk to high schools and people think, oh, maybe that's still too early. When I go into elementary schools, everybody's connected to the internet, and we need to have more information about that, and particularly that don't just talk to young women about this because they experience this more. Talk to young men about this as well, because oftentimes they're the perpetrators, and we need to look at why is that? How do we stop that from a young age?
Okay. Thank you. Ms. Gazan, please, for 2.5 minutes.
Yes, thank you very much. I want to go back into, training. I mean, I know that you're both researchers, but you're also scholars. At universities. Would you say that training needs to be changed, medical training specifically, because we're talking about postpartum, to include a focus on training training about for training around postpartum for women? Part of the reason I'm asking is because you've been very clear that, we become a vessel for babies, and then we become a physical entity after, separate from once we give birth. Wanted to hear your thoughts about that.
Sure, I'll start. Yeah, we need more training, but again, to be able to train people, we need to know what to train them and what is the evidence-based information that we can tell our healthcare practitioners. I also want to just underscore that postpartum is really important, but I don't want us to I don't want the women's health subcommittee, whatever, to only focus on the postpartum. It's the whole lifespan. I know you're not, but we talked about perimenopause, menopause, puberty. All of these time periods are really, really important and are so understudied in girls and women and gender diverse individuals.
So do you think it would be helpful to have programs specifically geared to women and gender diverse folks to enter the field? I know that this field is still predominantly populated by males. Do you think that would be helpful in changing some of the systemic barriers for women and gender diverse folks?
I mean, yes, I do. I do think that would be helpful to have increased representation within healthcare for women's health. Absolutely.
And empower women, right? Empower. This. If we tell people this is valued information, women's health is valued information to have, then more people will do it. Right now, it's so undervalued, and I think that's part of the problem.
So, and I share that because, and with all due respect, I'm glad that there's women around the table, but the health committee currently, in terms of regular members outside of one woman, is all men. Yeah. And I think that's demonstrative of the lack of focus on women's health issues in the system. Right?
Thank you, Ms. Kazan. Next.
Two now. Okay, there you go.
Ms. Roberts.
The problem is we're only 30% in the House of Commonly.
Yeah. Ms. Roberts, for 5 minutes, please.
Thank you very much, Mr. Chair. And I think my question's going to, I'm going to ask my questions to both Jean and Linda. And before I ask the question, the question I'm going to ask is, I need to know from your explanation the difference between state and non-state torture, because in Canada does not recognize non-state torture. And the reason I'm bringing this up is I'm sure everybody's heard about the young girl that was raped and tortured at 11 years old, Carrie Kehoe, and nobody believed her. Nobody believed that she was tortured. Nobody believed she was raped. The rapist, finally got arrested and was let out on parole. So she is reliving all her experiences all over again. So my question to you is, how do we change the justice system in this country to realize that that is torture, not abuse, it's torture, so that if we can make it torture, we can increase the sentences so that these guys don't have an opportunity to get out of jail and re-victimize the victims?
Great job.
Okay, that is an excellent question, because it's one Linda and I were shocked about in 1993 when Sarah came to us and said I was tortured. And we looked around and were shocked to find out that Canada does not recognize torture by non-state actors. So then we went global to try to understand the discrimination that occurs in the law, and we found out that in Canada, 269.1 says very clearly that the only tortures can be a public official, a police officer, or a military officer, because they didn't think that women and girls or children were ever tortured in the private domain. Because back then in the 80s, when the Convention Against Torture was created, violence against women and children in the family was a family matter. Everybody knew about it, but nobody paid any attention to it. So what has happened, in our opinion, is that when the convention was rolled out and it had discrimination in it, that it only happened really to men in warring or men in terrorism. that countries all over this planet decided to make a law that mimicked the convention, which said that it could only be a public official. Nobody ever thought of women. And Linda and I work with a group in Vienna, and we asked one of the experts when they were creating the convention, did you ever think of women and children? And he just said, no, it wasn't even a thought in our mind. So that created the discrimination, and it's rolled out across this planet. So for us, we think it's really important that the UN has been trying to change that attitude. For example, the Committee Against Torture in 2008 in paragraph 18 said very clearly that non-state actors commit torture, and the countries should look at that and change their law. And women and men in this country might be surprised that it was only in 1993 that it was acknowledged that abuse and torture of women, and they were talking about women at the Convention on Human Rights in 1993 in Vienna. That was the first time in the human rights history, really, around the conventions that the issue of abuse and torture of women came up in 1993. So we're very new at the issues that we're all talking about here. That's not very long time. So also the CEDAW committee, which is to remove discrimination, and Canada has ratified both of these conventions. They too are trying to catch up with modern times, and in their last recommendation, number 35, they also brought in non-state actors that they can commit torture.
So I want to just read from page 45. This is what torture is. It is the destruction of human being. It is the actions of a torturer that dehumanizes and attempts to destroy another human being. It is a bone-chilling reality. And I think, and I believe from reading your book, that this is what Sarah and some of the women that you helped have experienced. So we need to, at the federal level, ensure that we bring a law forward to change it, to let people know that what these victims are going through is not abuse, it's torture. And I got to tell you, some of the descriptions in the book, I mean, I had tears in my eyes just reading it, because this is what they're doing to our children. We as women have to stand up for them because our justice system has failed us.
I would like to add a little bit about babies for the discussion that we've had. The one issue that hasn't come up is that this can be intergenerational. And the women have told us that if that's not talked about in prenatal care, if it's not talked about in labor and delivery, that these families get missed. And the women that we've supported, all they ever wanted to do was to be taken out of their families. But if we don't name that torture can be happening in families, we have blank spots about our knowledge. So there's sufficient knowledge out there now that we can do better than we're doing.
Thank you. Les dernières questions seront posées.
And the last questions will be asked by Ms. Briere for the next 5 minutes.
And I want to thank you all for making a difference in the lives of women, mothers, and mothers-to-be. Je vais poser mes questions en français. Premièrement, sur...
I will be asking my questions in French. So in 2016, the Justice Committee looked into the different definitions of assault, torture, other kinds of infractions. And there are, of course, provisions in the criminal code, and some of these definitions are covered by these provisions. But I will ask my questions to Dr. Gallia and Dr. Fairbrother. You developed a series of online interventions for anxiety disorders connected to perinatality. So could you give us a bit more detail on that?
Not developed online intervention. So,
no. And me neither.
So there, I think what I could say is that maybe in large measure as a consequence of COVID, I think there's been a realization that we can broaden access to mental health treatment by having internet-based e-health interventions. This is particularly important for people who live in rural and remote communities who historically would have to travel long distances to access specialized care. In addition, it is possible, although I think we are still in need of additional data and research on this, it is possible that some combination of self-help by the patient themselves mixed with therapist support may be able to produce similar outcomes to face-to-face treatment at a much reduced cost. And I wish that I had knew a little bit more about how well that works. I know that if you remove the therapist support piece from internet-delivered therapies, the effectiveness of them drops through the floor. So you have to have the therapist support at exactly what dose in order to bring it up to the same level of effectiveness. I'm less confident.
Yeah, I think maybe what you are remembering is the Summit trial by Daisy Singla and others, Simone Weigood, and they look. And I'm not super familiar with it, but they were training non-professionals to be sort of like a therapist in certain situations in the postpartum, and it worked very well. So the trial results are released already. There's going to be more big announcements about it, but it does seem to be a low-cost, effective tool that can be used.
Okay. Merci, thank you. Vous avez aussi dit plus tôt.
You also mentioned that when we focus on the youngest children and the mother's mental health, there might be postpartum threats or pitfalls. If you can go into detail of that a bit more, please.
Yeah, I mean, I'm trying to think of how do we have healthy babies with unhealthy mothers, and I'm not really seeing how that can be. And so I think we need mentally healthy mothers to have healthy babies. And I think it's worth noting, this hasn't really come up today, but if you look at the data on unpaid domestic labor in Canada and who is doing this unpaid labor, it is still largely women. And as women, we are doing much more of the childcare typically compared with men. And so there's this additional burden which can also impact mental health. Having that weight of responsibility is also significant for women's mental health. And so I think we have to be paying attention to that.
Women are also more likely to be significant caregivers to their elderly parents as well, and that also plays a big burden. And I just wanted to say something about the Women's Health Committee and the percentage of men and males on the committee. We also need male allies. And so it can't just be about women helping women. It also has to be about men and gender diversity. We're stronger together, right? So I applaud the men that are on the committee, actually. Thank you.
Okay. What an excellent note to finish on. Thank you all for your very powerful presentations. Yes, Ms. Roberts.
I just want to say that I am so honored to be here today. I'm not normally on this committee, and I just want to say thank you to our panelists. It has been both educational and rewarding to know that there's someone out there fighting for us women. So a big round of applause.
Is it the will of the committee to adjourn the meeting?